There's been a recent reference circulating on Twitter about the use of bedside ultrasound to reduce cognitive errors, and I got to thinking how often it has been a game changer and saved my bacon. But at the same time, I also recognize that it also limits my thinking. I go looking for things that I can find with an ultrasound, and I often forget conditions that I won't see, such as a DKA causing breathlessness. So, begs the question, is bedside ultrasound a true forcing function, or does it confirm our biases? Do we see what we want to see? Well, here's a case of an elderly patient who presented very short of breath, cachectic, sitting upright, pursed lip breathing, in the middle of a very busy shift. Nursing notes recorded a prior history of COPD, and it appeared like this would be an infective exacerbation. In fact, I hoped it was an infective exacerbation because I knew we were out of coronary care beds. In the middle of this, of course, I had to sign ECGs. I got to the base of the right lung and then found the correct DCG, and by this time everything was hanging together nicely. A relatively dry lung with just a unilateral effusion and an area of collapse underneath. Uh, Infective exacerbation, bingo. But there was something nagging. Yeah, I remember in the base there was the odd distension of the IVC in the liver. I went back and had a look and thought, oh no, crikey, this is something else. I wondered, could this be PE? So is this where we stop? Do we have enough information now to go ahead and order a CTPA? Well, Professor Cross-Carey in his wonderful article suggests that we keep going a little further. I haven't reproduced his table on forcing strategies, but it's well worth a read. We should continue with the protocol. We should get as much information as we can. Because if we go in with assumptions, with bias, with focus, determined to find a particular diagnosis, we'll fall flat on our faces. Had the patient presented with hypotension or cardiac arrest, we might not have been so surprised with our diagnosis. Had we considered the cachexia as possibly due to malignancy, we might have gone looking for the not uncommon complication of malignant pericardial effusion. Instead, because this patient presented with breathlessness, we applied the blue protocol and almost missed the diagnosis. So in summary, the tool is not the answer to our problem. It's the practitioner himself who must hone his own skills. Professor Cross-Carey's article has some great suggestions about how we can improve our thinking. Many of these suggestions could and should be applied to our practice of bedside ultrasound.